my pleasure to introduce Nicolette. Nikki, if I may, Professor Nikki Roman is the South African Research Chair, Human Capabilities and Social Cohesion Through the Family, founder of the Centre for Interdisciplinary Studies of Children, Families and Society at the University of the Western Cape, and is visiting professor here at the School of Education and Professional Development at the University of Huddersfield. Nikki's work is founded in community and social justice and focuses on developing new knowledge and understanding of the potential of capabilities to improve the life chances of vulnerable families. She's an advisor to the South African government and several municipal governments in South Africa. In addition, Nikki leads on early childhood development at the University of the Western Cape. She's published and presented her research both nationally and internationally. Her networks are substantial, including visiting professor to Maastricht University, visiting professor to the Universidade Federal do Espírito Santo, Vitória in Brazil, and academic links with the University of Missouri and the Catholic University in Leuven, Belgium. Nikki is also coordinator of the Children and Youth Thematic Group of the Human Development and Capability Association. She has grown the critical mass in family science in South Africa through staff and student development, and is looking forward to engaging with students here at the University of Huddersfield. Over the past 2 years, Nikki has developed a partnership with our very own Dr. Jim Reid from the school and Hudcrest, and both are developing a programme of research involving the concept of family capabilities. And this evening's lecture is an introduction into this new and growing area of interest. So, without further ado, colleagues, please join me in welcoming Professor Nikki.
Thank you very much for that wonderful introduction. Good evening, everybody, and thank you for the opportunity to discuss the research focus, which is central to what I do. As a research chair in South Africa, I focus on the family. Tonight's discussion is going to be around family-centredness in healthcare, also known as FCC. So we know in healthcare, the focus is the patient, and so very person-centered, for the purpose of achieving well-being. In being person-centered, the intention is to provide as much information as possible to the patient so that informed decisions can be made around the care of the patient. We know that often the patient would require assistance in his or her care. Often this task is provided by a spouse or parent or family member or a neighbor or a friend. My interest is the contribution of the family as a group to the care and well-being of a patient. But why focus on families as the central facet in the care and well-being of the patient? So my discussion this evening is going to have 2 parts. The first part, I'd like to present some theories around understanding what families do. And in the second part is a scoping review of reviews that I did to support the science around this concept of being family-centered in healthcare. And I did that with the help of one of my postdocs, Dr. Zainab Kader. And hopefully within that, I can present a model that is out there already, but with a little adaptation. And so let's take a look at the theory. So there are 5 theories I'd like to speak to. My intention is not to go into too much detail, but just to lift out some facets of the theory which I think are relevant to understanding families. So the first one I'd like to focus on is the life course perspective. So that's a very broad theory, but specifically look at family life cycle framework. So if we look at the life course theory, family life cycle framework, it's basically that this theory looks at the developmental perspective of the family. And so there are various theorists who add into the family life cycle framework, and these theorists focus on the different stages through which a family evolves. So the family life cycle framework explains the changes in the family, such as unemployment or lack of income as an example. This may result in adjustments made to various aspects of the family, such as routines, traditions, and food security as an example. This may then also affect the behavior of family members as they are needing to adjust. The family life cycle framework is defined as the expansion, contraction, and realignment of the relationship system in order to support the entry, exit, and development of family members in a functional way. It is an interdisciplinary theory which seeks to identify the development of the individual and the family within both cultural and historical contexts over the lifespan, and how these contribute toward its operative functioning over time in relation to social conditions, environmental factors, and historical accounts. So, for example, saying with the example of having a lack of income or being unemployed, the effects on the family could be short-term. So, for example, the family doesn't have money immediately to buy food, which means skipping a meal. But also long-term, not having food or adequate nutrition will result in chronic illness or malnutrition. This situation could mean that family members will take on extra jobs for extra income or start maybe a small business. So what is basically saying that over a period of time, when there's changes in the family needs to adjust and adapt. Or maybe not. So the family life cycle framework allows for an exploration of the stages of the family life cycle and is able to identify the personal, social, and behavioral meanings and changes influencing families, which could result in a person's developmental outcomes in relation to the views of the family and the behaviors, boundaries, rules, expectations, and social cultural meanings that inform functioning in the family. Salikov and colleagues have developed 6 stages within this cycle. So the first one is leaving home, single young adults. The second is the joining of families through marriage. So this is the new couple. The third is families with young children. The fourth is families with adolescents. The fifth is launching children and moving on. And the sixth, families in later life. So while we understand these stages in terms of structural changes in the family, there are changes which could affect family members in different ways. So added to those stages, there's also other aspects which bring about change, such as divorce, illness, death and dying. How families cope and adapt depends on each individual, but also on how family functions in terms of values, culture, beliefs, practice, and relationships. So what it basically says to us, there are 6 stages within the family, and there are aspects which bring about change, but families cope differently, and that is what starts to help us understand around the complexities of families. So this was never more prominent than during COVID-19, a health pandemic which created a social, political, and economic nexus affecting families in different life cycles in various ways. Prominent of which was loss of health, loss of life, loss of income, loss of education, and so on. A very long list of change effects to which families had to adapt immediately. And also over a period of time because COVID disrupted patterns of what was considered the normal way of doing things. So this brings me to an understanding of how families function. Which is Bowen's family systems theory. So now we're going a little bit deeper into the family to see what's happening. The basic premise of family systems theory is that an individual should not be viewed in isolation, but in relation to interactions, transitions, and relationships within the family. What affects the individual affects the family and vice versa. The core foundation of systems theory is that all parts of the system are interconnected. In family systems theory, each member plays a specific role and must follow certain rules. This inadvertently produces expectations regarding the fulfillment of roles and responsibilities, communications, and interactions between family members and external systems, influencing the family, such as the environment. The family is presented as having 6 characteristics, which includes borders, roles, rules, hierarchy, climate, equilibrium. Those are only some characteristics. Some of the more obvious ones are roles, rules, equilibrium, disequilibrium, which speaks about consistent patterns and change. Family roles are what is expected of each family member. So someone is an aunt, someone's a mother, grandfather, niece. And then you have family members who take on certain roles, such as the clown of the family. Another person may be the responsible one. So that is some way of identifying what people do in the family. And then we have rules. Family rules are rules about how the family operates or functions. For example, when people are angry at each other, they express this in some way, or they keep it to themselves. How affectionate or emotional are family members expected or allowed to be with each other? How decisions are made within the family? Who has input? Who is expected to just go along? And how final decisions are made? How much are family members allowed to talk to each other, talk to people? And so it all depends on how families function together. Systems develop typical ways of being, which are reliable and predictable, which is due to changes or discrepancies which produce confusion. During difficult times in the home, rituals and customs help to keep the family together because they are typical ways of doing things, so it brings about a familiarity, especially with traditions. Whether these roles and rules are adaptive or not, there is a pull from the system not to change, but to continue functioning as things have always been. So the family is seen similar to a cot mobile. If you move one part, the other parts move. But if you let go of that one part, the whole system, that is the parts of the mobile, will pull each other together, pull each other back as to what they were before. This tendency of systems to keep doing things as they've already been done is known as homeostasis, or the system's equilibrium. As we start understanding the processes within the family, we realize how complex families can be, because often they are faced with different external factors and therefore also seek assistance outside of the family. A theory which is used quite widely to understand this interaction is Bronfenbrenner's ecological systems theory. Bronfenbrenner's bioecological systems theory has 5 systems, as indicated on the slide. It's the microsystem, mesosystem, exosystem, macrosystem, and chronosystem. I'm not going to go into detail, but what it basically says is that the theory focuses on the developing individual and explains how various systems interact within and across the systems over time. The systems closer to the individual affect him or her more, such as the microsystem, which contains the family, rather than the macrosystem, which contains policy, for example. Some families are able to navigate challenges or adversity relatively easily, which Walsh refers to as family resilience. Family resilience is the ability of a familial unit to withstand and rebound from adversity. The goals of family resilience approach are threefold. So it's reducing vulnerability in families, enhancing family functioning, and mobilizing family and community resources. This framework describes key processes that can strengthen a family's ability to withstand the crises or prolonged stresses that they face, and so improve family functioning. The view of family resilience does not mean that families are unaffected by adverse events. However, it views families as being capable of meeting these challenges effectively and having the ability to prosper. There are three overarching dimensions within which lies 9 keys to resilience. These are as follows. So, these are belief systems. These are shared beliefs which increase family functioning and is made up of 3 factors: having a positive outlook, valuing transcendence and spirituality, and making meaning of adversity. A family's belief system not only influenced but can also be influenced by various crises, challenges, and adverse experiences. The second one is family organizational systems. A family's routines and rituals, how they are developed, organized, and maintained, are influential in socialization, security, and affect reactions to stress. Welsh asserts that a family structure is important to its resilience and is strengthened by 3 factors: adaptability, flexibility and stability, connectedness, and social and economic resources. The third one is communication patterns. The complexity of family organization and subsystems might make communication between members more challenging. Communication is often cited as the main reason for problems within families and couples. Welsh describes 2 processes involved in communication: content and relationship. The content conveys facts, points, attitudes, beliefs, and so on. The relationship component often affirms, describes, defines, or challenges the relationship between these members. 3 factors within this dimension include clarity, emotional expression, and pleasurable interactions. And the last one is collaborative problem solving and preparedness. Studying families may not be everyone's cup of tea, because studying individuals may be easier rather than studying groups. But it is in the group which offers the possibility of 2 or more being better than 1. Within a group, there is the possibility of collective resources for resources sharing, support, and shared decision making. So this brings me to my final theory, which Dr. Jim Reed and I are working on as an emerging and evolving theory. Within the theory of capability theory, we're looking at family capabilities as an aspect of collective capabilities. And for this, we have submitted a paper which we have just received some positive feedback. And where this has its origin is in Nussbaum's human capability theory. And so what I have on the screen, I'm not going to go through all of them, but what I have on the screen are 10 capabilities of Nussbaum. And just I'll pick out 1 or 2. So for example, bodily health, which means being in good physical health, including reproductive health. You look at affiliation, which is subdivided into interactions with others. And what it basically means is relatedness or belongingness. And what Nussbaum basically says is that if you have these 10 human capabilities, you are living well with others and with yourself. So the theory focuses on the developing individual who needs the freedom to live a life of value, but draws on the group or family as a resource. So that is what we're proposing in the new theory. Groups offer safety and protection. Well-being, choices, and values of individuals are all influenced by the quality of the groups they associate with. Stewart identified 3 ways in which groups enhance the well-being and capabilities of individuals. The first one being When the group achieves or is successful in something, being a member of that group enhances the sense of well-being of each individual group member. The second point is, as a member of the group offers the possibility of resources and being able to do a task as efficiently as possible, having more help from team members rather than doing the task alone. And the third point is, often individuals become group members due to shared values, and it is this common values which influence the choices which individuals make regarding capabilities they consider valuable for themselves and for others. We propose that family, as a collective group of individuals, is a resource for individual well-being, because family or families help define who we are and who we are not, how we view the world, how we live, and how we share our lives with others. Like the individuals within them, families change over time. Throughout the world, families share many characteristics but differ dramatically in others. What we know is that the family, as a system in society, receives and drives other systems, but families are often not foregrounded as an important resource in positive ways. The family is therefore important in terms of the health system because the family is a social determinant of health. The World Health Organization in a 2013 report of the regional meeting in Bangkok in Thailand provides an understanding of the family and the contribution of the family in and to healthcare. The family is identified as a system that nurtures, socializes, and shapes the developing individual. If we consider the determinants of health, such as culture, economics, politics, then families are central either as determinants or as extenders of other determinants. This is especially relevant in health behavior. The World Health Organization proposes that interventions designed to modulate education and empowerment of individuals through families are an opportunity to contribute to society's health development. So I'd like to shift now to the reviews of reviews, the scoping reviews that we did. And so the purpose, on a first look at the literature and the science around the contribution of families to healthcare, there was a prolific amount of literature. And then we shifted to look at reviews that had been conducted. So the intention of the review was to understand the relationship between the family system and the health system, and how health situates the family in healthcare for individual and family well-being. So the scoping review was relatively open so that one is able to see what the review intentions were in an attempt to consolidate the relevant information from several review studies. So we had inclusion and exclusion criteria, and the inclusion criteria was that it had to be published in English because that is the language that we used. It was full text, peer-reviewed, and published in academic journals. We looked at all types of review methodologies, so it included the narrative review, systematic review, scoping reviews, and integrative reviews. And we looked at the last 10 years, which was 2012 to 2022, because my belief is that there were more reviews conducted in that time period than before. We excluded primary research, such as quantitative, qualitative, and mixed methods, because the intention was to look at reviews. We have not looked at the grey literature. We did not focus on children, because the natural assumption is that there's a family member with a child and the child is in healthcare. And so there should be an engagement with family members. We wanted to look at adults. And we also did not include somebody who has a disability, based on the same principle that often there is a family member with. Our search strategy was that we looked at electronic databases, and as you can see, just to name a few, we look at EBSCOhost, within that Academic Search Complete, Medline, Sinal. We looked at PubMed, SOS-Index. We used certain keywords and search terms, which was family-centered care and health, family-centeredness. And then, of course, we did some variations within the databases on those terms, which would include family and health condition reviews, family and illness, family and health management reviews. So the review process was that we first started with the titles to screen for eligibility and for duplicates. We then moved to abstracts, and then eventually we moved to the full text. So we then did some data extraction. So we created a data extraction tool based on year of publication, the title of the article, aims and objectives, the country where the studies was done, the types of illness, the sample size as well. And then we synthesized the data through thematic analysis. So this just gives you an idea of numbers that we had. We started with, on the first search, we had 3,421 publications. Through a title search, we ended up with 93. Through our abstract screening, we ended up with 78. We then looked at full text articles. We ended with 62. And in going through the full text articles, we found that there were 8 we needed to exclude based on our inclusion criteria. We then ended with a sample of 54. So this just gives us some of the results of the research. So we are still extracting data because it's quite a big sample. So I'm going to present just some of the information linked to the topic tonight. So a total of 54 studies were included in the research. And as you can see, there's 6 integrative reviews, 7 literature reviews, 4 narrative reviews, 6 scoping reviews, and 31 systematic reviews. These reviews were in various countries, and I've bolded because I'm from Africa. There was only one study in Africa, in Uganda, not even South Africa, which says we need to do research on this in South Africa. But you can see there's literature on this topic globally. And these were reviews, which means that it is a culmination of a group of studies focusing on a particular topic across the globe, which included family, focusing on healthcare. We also looked at the total number of participants in those 54 studies, and we had 296,107. The studies focused on various illnesses. Again, I'm not going to mention all, I'm just going to lift out. So there were studies on cancer, illness progression to end of life, diabetes, hypertension, some chronic illnesses, cardiac, high-risk cardiac patients as well. There were studies on COVID-19 too, those that had traumatic injury. And so based on our thematic analysis, there were some themes that came out of the data. So the first one was about the need for the involvement of the family. And some of the issues that have come up are the consequences of family participation, or maybe the effects of family participation. So it looked at the patient, family, and the health system. So most of the reviewed studies have shown that family members' participation in care, in healthcare, could provide the psychological, social, emotional, and physical consequences of older adult patients with critical illness. For the family, increased satisfaction with care, increased awareness, increased satisfaction with decision making, reduced worry and stress, increased families of having control over the care of their patients, empowerment in care, increased family integration, increased perception of illness, creating a sense of usefulness, improving coping mechanisms with disease, crisis, adaptation to the negative consequences of the disease. So what it basically says is the role of the family is important, and there is a need to involve the family within those articles that we reviewed. So family participation enabled relatives to feel in control and led to some ICU healthcare providers experiencing loss of control. So that is an example of a study that was conducted in ICU. Family participation allowed relatives to cope with and regain control over the situation and build resilience and adapt to the ICU environment. Some perceive family participation as empowering. So I've just used the ICU environment as an example, but this is the general feel through the review process that we did. So the key activities provided by the family included that there is a family member who accompanies the individual for healthcare. There is companion behaviors, which include recording the physician's instructions, facilitating doctors' understanding by relaying information regarding the patient's medical history or needs, asking questions, explaining the physician's instructions, and supporting medical decision-making. Then there were practical needs, help with assisting devices to help in managing the logistics of care provision, and applying for resources, which is often time-consuming, bureaucratic, and a source of stress. Then there's informational needs. Both patients and caregivers may need education on the terms and management of the disease, but there was also around sharing of information with family members by the health practitioners. And then there's, of course, personal time, and one of the things that have come up is coping strategies used by the caregivers, which are often spiritual, which can sustain hope and diminish despair. The best coping style used for more effective coping was task-oriented strategies, being task-focused rather than emotion-focused coping. Another theme that came out was around barriers to effectively include families in healthcare. As you know, communication was the most common challenge in the partnership. Not being inclusive in the partnership, so although the patient and physician perceived family members participating in the engagement to be important, family members often felt ignored by the physicians. The patient's perceptions of staff attitudes were also found to be influential and created a barrier. Physicians reported a lack of training in techniques to communicate with family members. Nurses reported a sense of stage fright in the relatively public space at the bedside, where their knowledge was perceived to be on show. Provision of care, support, and services in late life and or to older adult family members affected multiple domains of life. Studies reported higher levels of depression and mental distress amongst caregivers, often related to greater family strain and limited work supervisor support. Caregivers reported that their own health-related quality of life deteriorated based on the following reasons, which was that they prioritized caregiving over their own needs, their own declining health, and the emotional burden of seeing someone they love suffer. So, Coco Relius and colleagues developed a model. So they had also done a review, and they looked at a universal model of family-centered care. So their model, in the model they state that there's 5 main components of the family-centered care approach, which is collaboration, respect, dignity, activation and participation, information sharing and decision making. So these are all aspects which are important within the model that they have proposed. But what is important is And this is often an issue that, although family participates, there's a very instructional process in the literature, in the science, around how the health system interacts with the family system. So they provide education, they provide information, they will share around how things should be done. But one of the things that I noticed in doing the review, I'm setting this model aside, was that there was nothing around helping caregivers to cope and to manage. And so the mental health was something that, raised the red flag. But when I look at the model of Cocorelius, there was definitely a bidirectionality in the relationship between the family and the health, I'll say the health system, which is the health practitioner. So education and training happened in that the health care provider would provide them with information, but they would also ensure that the caregiver was taken care of in terms of coping through the process. But at the same time, the family shared information around their context. So remember when we spoke about the theories indicated that families are complex and they are context specific often. So although there's similarities, the context plays a role. So the family felt comfortable in order to share information with the healthcare practitioner so that the information that they received and the assistance and support and the resources could help the family better. So Cocorelius' model could be a universal model. But one of the things that it doesn't focus on is around educating the healthcare professional around how to manage families, how to understand families. So although there was communication and sharing of information, the healthcare professional is not necessarily trained in order to adapt to various families. And so some of the things that have come out, which is not necessarily addressed through the model, but we've picked it up within the review that we did. So the big one is around communication. So communicating with patients and families about illness progressions and end of life is something that was found by Egberg and colleagues. That was a recent review that was done in 2021. So this review was across diverse aspects of clinical practice to manage difficult conversations. So it was a very interesting article, and it included COVID-19 as a focus as well. And within this review, they've come up with recommendations. And what they're basically saying is that there's direct and indirect conversations happening. So we know that when we communicate, we don't just communicate with words, we actually communicate with our body language as well. And so they have looked at all of those aspects around communication between the family and the healthcare provider, and they've come up with some recommendations, which I think was quite relevant. So recommendation 1 was to ascertain a patient or family member's perspective before offering information. So what they're basically saying is that the healthcare practitioner should first consider the family's perspective. So they need to find out what a family member would like to get out of the conversation by providing opportunities for family members to raise matters that they would like to discuss. Secondly, they should try to find out the family member's perspective about the future as well. The second recommendation was, where possible, mirror the language of the patient or family. If a family member discusses the future indirectly or elusively, they should try to do the same without increasing ambiguity or concealing fateful outcomes. As the conversation progresses, a shift may happen to a more direct conversation. The third recommendation was around creating opportunities to discuss the future. highlighting connections between the family member or a patient, what is expected, using hypothetical scenarios in order to explore possibilities, referring to illness progression. The fourth recommendation was about being clear about uncertainty and acknowledging the components of the patient's future that are uncertain. And of course, the fifth one is to display some sensitivity, because there has been, in the literature, in the reviews that we did, it seemed that some healthcare practitioners weren't as sensitive to the family's participation and sharing of information. And of course, in sensitivity, being conscious of verbal and non-verbal approaches to addressing communication or communicating with the patient and the family. And so out of our review, some of the aspects that have come up is around future research. So one of the things that has actually stood out across all the reviews was that in the scoping review we did, it was very descriptive around experiences of families, interacting with families from the healthcare practitioner, but there wasn't research done on an evaluation of whether a difference was made to the well-being of the individual. And what they're basically indicating is that there should be more RCTs in order to test that family care, family-centered care makes a difference and vice versa. Although so it's more from a qualitative perspective that people are saying it does make a difference, rather than being tested. There's also the recommendation that the models should be translated into practice, so it's still very conceptual. And it is essential to explore the family structure, because we know that different families, extended families, looking at single parent families, they have different contexts, different needs. So it is essential to explore the family structure and to understand the family experience of living with a condition or disease, so that professionals can have valuable knowledge to support families to deal with the responsibility of caring for the family member. And then, of course, there were aspects around practice. So ask patients and families what engagement means to them and what aspects of engagement matters most to them. Explicitly invite and welcome family presence at medical visits, if the patient prefers, and provide patients and families with evidence-based strategies that have been shown to enhance patient-provider communication. Include patient and family advisors in design and implementation of research, interpretation, and dissemination of research findings after proper training. So communication and training were the two main aspects that have come out of the review. Train future members of the healthcare workforce, such as physicians, nurses, social workers, medical assistants, and administrative staff, in the principles of patient-family education, and set the expectation that excellence in this area is a requirement for the job. Assess the level of engagement of patient and families in shared decision-making, care planning, transition planning, all aspects of community partnering and patient-family care experience, and continually engage in various aspects of engagement and providing feedback on clinical experience as well to providers and clinical practitioners. To encourage patient engagement in decision-making, consider asking the following two questions. What are you worried about? What are your goals following treatment? And so I've got a red piece there. So it was not clear how challenges in families are accommodated for in the partnership, or how to identify strengths in the family. In conclusion, there's a take-home message. Engaging patients and families as active partners in their health and healthcare should not be a privilege afforded to a select group, but a right to all patients. Care plans are needed which consider the family context, as it cannot be a one-size-fits-all, given that family is a complex phenomenon. Policies and procedures need to be flexible, incorporate family-centered care to create system-level change. For successful family-centered care implementation, all these elements should be considered. Flexibility and adaptability are needed, supporting autonomy and agency, active exchange of information, honoring difference and uncertainty. And so while there's a prolific amount of information, the science on this aspect, there are definite gaps which should be considered and maybe explored a little bit further. What has come out is that communication and training, education, are the big factors in this field. So we are still exploring the data, and hopefully we'll come up with a little bit more. Thank you.
Thank you.
Thank you so much. That was absolutely fascinating. Colleagues, we have a little time for some questions. Over to the floor. Any questions?
Hi, thank you very much. I really enjoyed that. That was fascinating.
Pleasure.
And lots to think about. I wondered in the findings or what you came across, was there anything that drew out about health literacy? Because I really like that last statement around it being a right and it's not a privilege for the few, as it were. But obviously for people to be engaged, even when you've got staff trained, there is the impact of the difference in health literacy. I wondered if that came out.
Yeah, so there's inconsistencies in the type of information that is shared. So you will find in the literature that in policy, for example, families are mentioned. And so you need to have, you should encourage families to participate. But when it comes to sharing information, that's where the consistency is. So in terms of health literacy, yes, they will provide, whether it's a booklet, whether it's verbal exchanges. But I got the sense that it was very surface level and not really engaging and providing the information. And like the one statement was around, they feel almost ignored. So they'll deal with the patient because the patient is the person who needs the information and not necessarily the family, and the family is just there to view everything. So to answer your question, yes, there was something around health literacy, but not to the extent that I can tell you that they had training or formal type of sessions that is being done.
They wouldn't necessarily tailor and adapt their communication to ensure that people could be engaged.
Yeah, because the idea is that this is what you need to do. So it's task focused. This is what you need to do. Here's the information. Go off and do it. In some cases, they wouldn't monitor that it was being done or how it evolved and whether there was an improvement. And I think that relates then to the mental health of the carer, because that stress of am I doing this correctly and nobody's really monitoring, am I not perhaps doing something worse rather than improving well-being. So if we look at family-centredness in healthcare, and we're talking about individual well-being and family well-being, those are the types of things that may actually impact on well-being. And so there is a push towards, when I looked at the model, was that while they were looking at the caregiver's mental health, it was not explicit as to who does it, or how it's done, or where it happens, or who's monitoring that process as well. So there's quite a bit of room for additional research and for practice.
Thank you.
Thank you. Thanks. I really enjoyed that, Nicola. Thank you so much. And my question, I guess, sort of follows up a little bit on yours, I think, because So I was really interested in how you started the lecture with those really interesting models that demonstrate how complex families are. And then I was thinking about what you just said about not necessarily accommodating the existing literacy within the family, the health literacies. But I was wondering whether there's any evidence about how health professionals do see families as complex, or are they making assumptions about family functioning when they sort of, when they educate?
So there's nothing explicit, but when you read through the reviews, you start to realize that it's a one-size-fits-all. So when you look at the family and there's the patient, I'm not really interested in what you're going through or how different you are or the challenges or crises that you have, that you've been faced with. Here is the information around how the patient should be cared for. And if you do have any challenges, there's social workers who could assist you. And so that raises the question of whose job is it actually when we start looking at challenges in families and differences in families. And I think that is not answered yet, because in my opinion, I was looking for an article that speaks about a whole society approach, or a multidisciplinary approach, but just looking at who does what within the care while including the family. But I haven't come across that yet. So to answer your question, I don't think that diversity and the complexity is realized in when providing information and the care for the patient. But it's definitely something that has raised, within the study, it's definitely a recommendation for further research and consideration.
Did you come across anything about how the delivery of healthcare, they changed, kind of the organisational delivery to improve engagement with families? Because obviously a lot of the time, if you think about hospital care, the ward rounds are when actually families aren't there because visiting times are later, which means that for families it's very difficult to engage. And I think actually in terms of community care, a lot of the times it might be that if you've got an informal, you've got a family member that's providing informal care, it might be when they're working or they have other commitments, and the barriers to being able to engage and have those conversations. So did anything come up about how perhaps any of the systems adapted to be able to make sure that there was or they promoted engagement with families?
Yeah, so there were very few articles which indicated the various stages of transition within the care and within information sharing. So there were articles that would, for example, say, and I'll use the example of the round change. Maybe there is a part where they share that information on changing ward rounds, and so if the family is present, they would then get some of that information. But then there were actually practitioners who would sit down, and often it's the nurse's role, to sit down with the family and to discuss the information. But I haven't found too much, and like I said, we're still busy working through the data, but that is definitely something that we can look at to see if it does come up. But there was some of it, but not very clear. But like I said, lots of inconsistencies. So there's some perfect ways of doing things, and then there's others that's a little bit questionable. And then there's the ones that don't really consider the family. No.
Another problem. A couple of things, maybe, but I wonder if any of the reviews highlighted. We talk about families unproblematically as a concept. Did any of them do the additional work of unpicking what family is?
No.
For example, and I'm thinking, here we are in the UK, you're from South Africa, and actually
very different
understandings of family. So I wondered if you could say something about that difference or that lack of acknowledgement of difference in what a family is or isn't.
Yeah. So one of the recommendations of mine that have come out of the review, and there were articles that actually said, you need to define what a family is. I purposefully didn't define what a family is because I believe that there's flexibility within the definition. And once you have the flexibility, it's basically acknowledging that it's who the patient calls family. It may not be blood, or by marriage, or by other kin ties, you know. In terms of defining, that was a big one in the literature that was absent. And there were 1 or 2 articles that raised the point about saying you should define the family so that you can understand the context. And they should be defining who their family is and what their family does. But the big one around what families do, was not there.
Follow-up question. So if there's no definition of family, and if we have diverse understandings of family, and there are different structures and models of family, are the 5 theories relevant to today or to different contexts, or is there a need for, I suppose, your theory, your new theory, that would address that uncertainty or that lack of definition?
Look, I think conceptually theories are important, even the older ones, because it provides at least a structure for understanding family. For example, how the system functions in terms of rules, boundaries, decision-making, how change affects families. So I think they're still very relevant because that gives us the similarities of what a family is. But what they miss is the context. And so when change comes about, there are some theories who speak about change. And so that links to disequilibrium, so that is acceptable, you know, so we understand that's relevant in today, like divorce, for example. But then when we try to understand what families do, that's where the gap is. And I think maybe we're going to fill that gap, Jim. Yeah. So then it's about what are the new things that one could develop and look at in terms of families and how they function in their context. And that may then mean that we have to revisit some of the definitions around family.
I mean, it can maybe add a sort of another illustration of that, and it draws on David Morgan's work. And he talks about lots of concepts and discussions and lots of policy work and theories around family, treat family as an arm, as some sort of structure, and then that becomes further defined when you think about family as an adjective. So we've got families that are poor families, or families that have illness, or families within which there is wealth. You know, so we have those sort of descriptive tropes. But what there isn't is any, I guess, consistent or really any work around family as a verb. And understanding what it is that families actually do. So when you think about communication, it's not just the act of communication, it's the actual work of communication, for example, and how that occurs within families, because that will be different depending on the family and how the family defines itself. And that's what we're trying to sort of pick at. And so I think we need to think about nouns and adjectives, but we also need to add to that richness in terms of verbs. It's another way of thinking about it.
Thank you.
It's a pleasure. Thank you.